back them. Well, yes, we have two representatives, myself and Pastor, Reverend. All right, three. And Joseph, sorry, three, three. All right. So thanks for the introduction, Kemi. And I mean, there are a lot of common conditions that would affect different ages of women. We will not be able to speak on all, but if it is not covered here, we'll go through section by section in terms of each body part. And before we close off, for example, like the ovary, before we close off on that, we'll take questions. So if something is not covered, or even if it's not part of the systems that you're seeing, still ask the questions. We are family, we're here talking, and I mean, you all came, so you're all taking an interest in your health, so that's very important. Okay? All right, good. Right, so the topic. So I was trying to see how we could do this. So before we even start about anything, I think we look through what the body parts are. Right? So we go into a little anatomy of the female reproductive system. All right? So everyone is familiar with this picture, yeah? So we're looking at the entire womb here, the cervix, the ovary, and then your tubes. We're paying special attention to, in the womb, the three parts. We're seeing this lining here. This is what would be built and shed, causing your periods. All right? This is the endometrium. So I'm going to be using that terminology going forward. Then we're looking at the muscle part of the womb, which is the myometrium. All right? Those are the two main parts of the womb we'll be looking at. The cervix, we stay with the cervix. Ovary, we stay with the ovary. All right? Anatomy session over. So we go forward again. Right. So a lot of we need to know what is normal before we look at what is abnormal. And a lot of the management for any issue with respect to the womb or the uterus is managed using hormone therapy. You have non-hormonal therapy, hormonal therapy, or surgical options. All right? So we need to understand what the natural cycle is. Okay? So it's a bit busy, so I'm using my little red pointer here. Right? We want to take focus on this first row. This first row is showing the lining of the womb, the endometrium that we saw before, and it shows how it changes throughout a woman's menstrual cycle. So towards the bottom here, we're looking at the days. So first day of your period, we start off here, so that'll be day one of your cycle. At that point, an already present endometrial lining of the womb, starts to shed, and you see it starting to come down here. As it sheds once there's no pregnancy, it starts to shed. That's the period. Depending, everyone is different. Could be 5 days, could be 7 days. Just to keep it simple, we're looking at 5 days here on a 28-day cycle. A normal cycle could be from 21 days up until less than 35 days. So that is normal. Anything above or below that would be abnormal and needs investigation. So what would cause these changes? We're going to pay attention now to this row here, which is the hormone released by the ovary. There are two main ones. They are estrogen and progesterone, terms that everyone should have met at some point. All right, so all these hormones are low, and that would cause are low now during the period, and that will cause the periods to talking too soft. Okay, I need to talk louder. My apologies. Right. You want me to go over anything so far? All right, good. So So once the periods are finished, the estrogen, that is the one, that is the hormone that will build the lining of the womb. So as you see the estrogen starts to build here, you see the lining of the womb starts to build as well. All this is in preparation for a potential pregnancy. The biological purpose of life is to, on scientific biological terms, is to contribute to the genetic pool. So the body is doing what it has to do on both male and female sides to prepare to reproduce. So all this is in preparation for that. So we need to understand this, and then we'll see how the changes in these preparations would manifest as certain medical problems. So you see the build-up here, and the progesterone is low. So once the estrogen maxes out here, other hormones, we're not going to pay too much attention to that, but they are important, will be triggered, and this will cause release of an egg, which has been selected from before and just increased in size up until the point of ovulation. And it is released, and then it joins into is released and is picked up here by the fimbrial end, and it goes on this journey waiting to meet with a sperm somewhere here and get pregnant and then implant here. Then become fertilized and then get implanted here. Now, what will maintain the lining of the womb? Okay, so the estrogen is there and then it starts to drop off. This hormone will now come into play. This is the progesterone. And this will maintain the lining of the womb. Important to know, because a lot of the medication that will be used for certain things will be progesterone based. It will maintain the lining of the womb, whether it be thick, as we see here, or whether it is thin. So if we started off using this hormone where it was thin, it will maintain it there. So you can see how helpful that will be for certain things. All right, and then there's no pregnancy, everything trails off, and we start back here. All right, good. So that's a bit of physiology of the menstrual cycle. Important to know as we go forward. So, bleeding, the most common condition that we'll see in the clinics would be bleeding, whether it is in the premenopausal woman or in the postmenopausal woman or even the perimenopausal woman. We'll explain the differences between perimenopausal and postmenopausal in a bit. But I think premenopausal, everyone should understand that is someone who is still going through their periods, right? On average, less than 50, 52, okay? So some of the causes of this type of bleeding could be some structural changes, like fibroids. We'll talk about that because that's a common one. A condition called adenomyosis. We'll explain a little bit about what that, if it's a bit unfamiliar. Then there are polyps, and then there are the cancers and the precancerous conditions. And then they have the non-structural conditions, like if someone has an inherent bleeding disorder, they are more prone to bleeding, to easy bruising, then they would be more likely to have abnormal bleeding on a normal period. A hormonal imbalance, or even some devices that we use, the ones that we put inside the womb, some could cause abnormal bleeding temporarily, and some that lack the hormone could cause it to be a bit heavier. All right, so we're going on to fibroids. So far, do you have any questions? Or anything? No? All right. So fibroids, everyone knows about this. We hear it called fry balls sometimes, but it is fibroids. And it is very common in our population, very common. A lot of women don't even know they have fibroids, and they just pick it up because maybe they had a tummy pain and they did an ultrasound and, hey, look, a fibroid. And then they want to know, well, what to do? Do I need to do something? And mainly, if it is not causing problems, we leave it alone. All right? That's the general take all over. Because you just happen to find a 2 centimeter fibroid. You want to do, because everything has side effects. You had to use some medication. Some people might want to talk about surgery or other interventions that come with risks where for something that was not causing any problems and more than likely is not going to cause any problems. All right? But we're going to talk a bit more. So what are fibroids? Remember that muscle layer we were talking about? It's a tumor. It's an abnormal growth of part of that muscle layer. All right? It tends to look circular, but it could come in all different shapes. All right? The rate at which they grow is different for everyone. For some persons, it might grow over 10 years, 1 centimeter. For some persons, it might grow 20 centimeters in 3 years, which is like a full baby. All right? It's very common. About 30 in 100 women have it. More prone in the African population, the Afro-Caribbean population, for persons who have a high height to weight ratio, a BMI, body mass index. It is mainly non-cancerous, but in a small number of women, 1 in 1,000 women, it will be cancerous. How we will know is the rate at which it grows in size. It will be rapid. Like in 1 year, it moves from 2 centimeters to 7 centimeters. It's like, yo, that growing too fast, this needs to be investigated. All right? So, and the effects would be all dependent on the location. Keep in mind, in the back of the mind, the picture that we saw, the anatomy picture. It depends on the size of the fibroid. Obviously, something that is bigger, there's only so much space we have in our tummies. So if something is like a twin pregnancy, you can see that that could cause mass effects, squeeze all the other organs and cause dysfunction there. The location, there are the different parts of the lining of the womb. If it is in the endometrial layer, near the part that will shed in your periods, that woman would experience, for a very small fibroid, heavy periods. All right, as opposed to if it were in another locations deep within the muscle layer, less likely to cause problems. All right, yeah. With the fibroid, right? Most of the times it's not cancerous. Yeah. Most of the times, but that's a common concern, that question you asked there. That's like someone will incidentally find it on an ultrasound, and they will come seeking an opinion, like it wasn't causing any problems, periods nice, small, 2-3 centimeters, but they want it out because of what they believe. They believe that it may be cancer. Now, there are no absolutes. 1 in 1,000 is pretty good odds, but it avoids doing a surgery for everybody or intervening for everybody who have a fibroid, which would be a large number, especially in our population at Trinidad. All right, any other questions? Sorry? Right, so we're coming up to that. The next slide is we don't know for sure, but there are certain things that will predispose a woman to having it. The strong belief is, well, one, genetics tend to be in families, and then again, 2 sisters might have it, and then the 3rd sister good. So there are no absolutes again. So it tends to run in family, but it's not absolute. All right? Hormones. This is the major thought. And why we believe that is because now estrogen here is the culprit. And why we believe it is estrogen is because when a woman would, who was known to have fibroids, let's say wasn't causing any problems, but we know it is there, and we were following her up. The majority of these women, once they go through menopause, the fibroid shrinks. It shrinks. So now the shrinkage is all relative. Huh? You can't start off with fibroids big like this and then expect it to shrink like this, and then it will not shrink down to nothing. Whereas those small ones that are not really causing problems, you could have multiple small ones, and if each one shrinks down somewhat, it actually, if it's plenty, it will actually shrink the whole womb, and that woman is happy. Avoid surgery.
Wait.
So,
we need to repeat the question.
A good question.
The fry. Yeah.
All right, so the question is, do the fibroids stay inside the womb or if they could go outside the womb? It's a good question. So fibroid location, so yeah, it could be they all arise from the womb, yes. So it could be it could be what we call subserosal, which is just underneath the outside. This is unlikely to contribute to heavy bleeding because of its distance away from the lining of the womb, but it could cause mass effects if it's like big like that, right? Submucosal, which is a problematic one, which is just underneath the lining of the womb, which is bleeding. In the womb, intramural, in the muscle, if you have a lot of that, they could contribute to a total increase in size. If you have 22 centimeter fibroids, the size of the womb, which is supposed to be about 7 centimeters, could increase plenty. And the one that would be on the outside is not illustrated here, but is something called a pedunculated fibroid, where it's like if you picture a mango hanging from a tree, you have a stalk, and then you have the fibroid. So it could present like that as well. And those ones could contribute to some pain, because just as you would twist off the mango like that, twisting of anything in the body would cause pain because it would be blocking the blood supply to that fibroid. The fibroids are very greedy. They love blood. They love blood. So depending on the number, the amount, persons could have low blood count and come in and just find out they have the fibroids if it wasn't big enough to see your tummy actually swelling. They could actually have low blood count and come in and incidentally find out, hey, what causing this blood count? And then you do ultrasound, you see fibroids, and is that all right? But good question. Keep them coming. Yeah. Well, it's like I equate it to prostate cancer. That was the last talk we did. That's an Afro-Caribbean man thing as well. I'm sure they have studies, but nothing solid for you to say, in this person is going to happen. This is just something that they observe. And I'm sure at some point in life they'd have something stronger where we'd be able to say definitively, this gene causing that, and this gene is present in Afro women, and at some point, but I don't have that now. All right. Good. So we talk about the hormone factors. Estrogen, culprit. Menopause removes the hormone, possible shrinkage. Age. Tend not to see it in young women, particularly between the age of 30 and 40 would be when it first presents. Obesity, the higher body weight may be associated with an increased risk with the high, we call it BMI, the high body mass index. This is very important, which is why I wanted to show you all the hormones, because the different parts of your body would produce hormones. The ovaries, we know, would produce the estrogen as well as the progesterone. But there's also other places we call peripheral. So centrally, we have the ovaries producing these hormones, and peripherally, which would be deposited inside the fatty tissue, it could store certain it's cholesterol, and this cholesterol would be changed to different things. So every woman will have some degree of male hormone in them, which is normal. Same as men, we would have some degree of female hormones, which should be normal. Above normal, you'll start to see it being manifested by deep voice, hair loss, male pattern baldness, you know. So there's a normal range for male hormones in women, and vice versa. So this peripheral release of the estrogen will contribute to your total estrogen there, so it could cause certain things. One would be the fibroids. Not to say, remember, there are no absolutes. This is just something that they are saying, because someone could be a higher body mass index and have no fibroids, no issues with their periods, they're good. And then someone on the other side, everything going on. So there are no absolutes, it's just something that we have to take note of. And this is the thought process as to how the obesity could contribute to it. Right, so the question is, if a woman does not get pregnant, if that would increase her chance of getting fibroids.
No, it's not a cause to not get pregnant.
Yeah. Well, I have to be careful. It can contribute to infertility. I think I have a slide on that, right? But I love the questions. So just to finish off the slide, and then we'll go forward. So diet could also contribute to it. Certain foods like red meat, low intake of green leafy vegetables may influence fibroid development. So the symptoms: heavy bleeding, we remember the location, painful periods, the womb is a muscle, you have something within that muscle that shouldn't be there, could contribute to painful periods, longer and more frequent periods, often lasting 7 days or more, pelvic pressure or pain, again, depending on the size of it. Sometimes these fibroids, if they are large, they could squeeze on the tube that drains the kidneys. So there's a tube that drains the kidney into the bladder, and then you have your PP tube from the bladder to the outside. So if the fibroid is large, it can squeeze. So behind here somewhere is a kidney, and then there's a tube that comes down here, and in front of this fibroid, in front of this womb, you all will know, in front of the womb is the bladder, for those who were pregnant, if they remember, right? So it drains here. So if there's a fibroid that is large, that is squeezing on this tube, you can get a backup into a kidney, and that could cause the kidney to be damaged. So that's one of the pressure symptoms that could happen. So pelvic pressure or pain, and then again, it could be just like a baby. If your bladder is expected to be filled like this, and then something is squeezing on it, so it could only fill up to this point, you go into the toilet more often, right? So it could contribute to that. Frequent urination and difficulty in urinating. It can cause the outflow tube from the bladder to be kinked, depending on the location and the size of the fibroid. causing problems where you have to manipulate, some persons will have to manipulate their tummy just to get some pee out, and it could be affect their quality of life. I start back talking soft. Alright. Okay. And then the pain during sex and potential fertility challenges. So this is your tube here. Your tube opens into the womb through what we call the cornu on either side. Provided that this tube is open and free and clear and working properly. If there's a fibroid that is around this side here, then that would affect the sperm meeting up, or even if the sperm does slip through and fertilizes an egg here, the fertilized egg will not be able to pass here. So for persons who have to, for fertility reasons, have surgical intervention for fibroids, what we do, just to confirm, is we have them do an HSG. That's where they push a dye into the womb to see if it passes. And while they push the dye, they do x-rays over a period of time to see that, one, it can fill up and show us the cavity of the womb. Two, it can show us that this is being filled because there's only one exit once we push the dye here. And that exit will be through this side here to see that it spills out. So that's one of the tests that we will do before, just to see if the fibroid that we suspect to be in this location, if we do a surgery, if it will work. So yeah, it could contribute. And if it is not there, and it is a large fibroid, remember the egg needs to be implanted here along the lining of the womb, right? It needs to be implanted in a nice, non-hostile area. So if that area is hostile, meaning there's a fibroid there, it won't be conducive to implantation, and there's a chance of miscarrying. Not to say women who have fibroids can't become pregnant and carry a pregnancy through term. Yeah.
So, oops. Right. So that same scenario, more or less, that you were sharing, is that what will contribute to what we call an ectopic pregnancy, where you have the blockage, and therefore...
Good question. Now, fibroids, I'll probably explain it not too good, but fibroids are really implicated in ectopic pregnancy, but based on how I explain it, I could see why you're thinking that. Because it's unlikely for fertilization to even occur if there is a fibroid that is blocking here, right? But, yeah, it's more with scar tissue from infection here will contribute to that, or having an intrauterine device, one of the coils. If you become pregnant, there's a chance that, because the coil will make here hostile. So anything that passes through this hostile desert, because of the coil that we place and gets here and becomes fertilized here, they won't want to come back here into this hostile area. But fibroids are not implicated in ectopic pregnancy, but I could understand what the question because of how I explained it. All right? We good? Yeah? I don't think it on.
Sorry. In an instant where someone has had fibroid surgery, and you say that dependent on the size, that the fibroid pushes organs and other stuff out of whack then. Now, I'm specifying on the urinary area. Mm-hmm. Would, after the fibroids has been extracted...
So this person did surgery to remove it?
Yes.
Right, good.
Would that cause permanent damage to the urinary pathway then?
I understand the question. Right. So I imagine that the surgery was done because this person was having symptoms based on the story, probably urinary symptoms, right? Now, which came first, the chicken or the egg? Right? So that's, all right. Okay. I try to keep it. Did you, sorry to interrupt, did you do any urodynamic studies? Is that a study where you had to pee and then they put something inside your pee-pee passage to check your pressures? Okay. Okay, sorry. Go ahead.
I just experienced that since then it's like it oh God, how should I put this? It's been more frequent.
It got worse after the surgery?
Yeah, normally I would be able to sleep through the night, but now it's like every, I wouldn't say hour and a half or so. I'd get 4 or
Okay.
5 times for the night.
Right. So more than likely then because that's an outflow thing, so more than likely the fibroids would not have had anything to do with that. There's another topic. There's another topic called urinary incontinence, which is something that is common where persons don't have the ability to keep urine up. One, it could be caused by a trigger, a stress urinary incontinence, where every time you cough, pee come down, or you're doing your exercising, pee come down. And then the next one is urgency, where you move from 0 to add a pee, just so, and it happens regularly, frequently as well.
But the thing about that is, during the day I'm fine. I can go all day.
Okay.
But it's just during the night.
What I recommend, because they have excellent treatment, I'll give you like 70 in 100 women will get symptom-free after a certain time, 6 months.
Really?
And it would not require any major intervention, so I suggest having a conversation with a gynecologist. Because you have to do a full history examination and stuff like that to rule out other things. But just on this light talk we're talking, you'll need, because physiotherapy could even help with that. Supervised physiotherapy, right? Pelvic floor muscle exercises, together with what we call bladder retraining, and that is just that is no intervention, but excellent option with high successes. And a lot of people think it's normal to go through this, or maybe, okay, it happened, okay, let me just deal with it. But there are things, and that's just one layer. If that doesn't work or you're not satisfied, they have about 4 different layers that they could use. All right? Okay, but good question. Right. So symptoms, fertility, we talk about that. We went on to another topic. I mean, that's a nice topic, though. Management, good. So the main thing was to only intervene when symptomatic. If it's not causing any problem, leave it alone. Management could be either medical. This UAE is umbilical artery embolization, I'll explain that, or surgical. So medical, depending on what your primary problem is. If it's bleeding, you could use non-hormonal therapy, form of certain tablets. The next one would be hormonal. Yeah, either keeping the lining of the womb thin by using progesterone, either tablets or inserts. Excellent medication which provides contraceptive cover. As well reduces the chance of the lining of the womb becoming abnormal, precancerous, is something like Mirena. You've heard about it. It's an excellent drug. Umbilical artery embolization, this is an option, non-surgical, but for the woman who has already completed their family. You're not looking to get pregnant. This is where a certain person, those doctors who do scans, radiologists, there's a certain type of radiologist called an interventional radiologist that can push a dye into the vessels that supply the womb. So along either side here, there are vessels. The womb is to supply life. A life form grows there. So there are vessels from this way, they have lots of vessels. So what the interventional radiologist will do in that UAE technique is push a substance, a gel-like substance, into those vessels, block them, block that blood supply. It's not total blockage because you'll still be getting from here, but they'll block it, and the amount of blood that will be bringing certain hormones as well as blood, remember the fibroids are greedy, to the fibroids will decrease, fibroids shrink, and it's a good option. But it may require re-intervention, repeat after about 5 years and about 25 in 100 women. So it's good, but not 100%. But for someone who wants to avoid surgery, the option is there. Yeah. It didn't work. Yeah. Yeah. So the next one.
I have a question. What about the procedure called laparoscopic myomectomy?
Right. Laparoscopic myomectomy. So that's another option, correct? Surgical. But not as invasive. So it's like you're going to, they put in a camera. So you come in, it's a day procedure. They may sedate you or just numb around the area. They pass an instrument into the womb here, fill it with, they push some salt water, saline, to visualize the structure there. And this is only done for certain types of fibroids. So fibroids are graded from 0 to 7. Based on their location from the lining here outward. So 0 would be in the lining, 1 will be more than 50% will be outside here. So that is only an option for grade 0 and grade 1. And to properly map it, a CT scan or an ultrasound may not be sufficient. So to do that, they will need to do MRI. So you have to do an MRI, make sure they map it and be like, okay, this is grade X, whatever. And then they would be able to decide whether that person would be a candidate. And how the procedure is done after you visualize it, after putting the saline, there's a little drill, kind of like a pencil, with a little drill and a suction, and it just shaves it off. Imagine like a cone. Imagine like a cone, and you just shave it off until it is, no, the technique, and you're just shaving it off. But again, it all depends on how much should be remaining here, because you're not going to do that procedure for this one, for example. This won't qualify, because the majority of that fibroid is within the muscle substance. So yeah, it is an option, but it won't work for all. There's no way you could shave this one, for example. Yeah? So it depends on grade 0, grade 1. There are many grades. In order to grade it accurately, you should do an MRI. So, and this is not offered publicly, so the expenses would be pretty high. No, not only to do the procedure, I mean insurance, but because you'll need investigations to be sure that you could get it done. And MRI is, yeah, to map it. They call it fibroid mapping. So they will do that. If they're planning to do this surgery, yeah. Yeah. But good question. Any other question? Okay. So, we okay with fibroids? All right, good. Yeah, the speed up. Right, so This is the second topic. So adenomyosis. So we're going back to the picture. I should have had a picture for every area. So adenomyosis. This is where we have the lining of the womb. We remember the endometrium invading the muscle part. It's not supposed to invade. It's supposed to be there where it can build and shed and come out as a period. When it invades the muscle part, that is where it's not supposed to be. That is called adenomyosis. Now, endometriosis, that's something that is common as well. We're not going to talk too much about that, but that is, I need to mention it because it is another condition where we have the lining of the womb tissue being in places it's not. So with adenomyosis, is inside the muscle part. With endometriosis, it's either in the ovary, outside on the tubes, so you can see that could contribute to infertility. It could be anywhere in the body, anywhere, and it will follow your menstrual period. So if it's on your bowel, the poo-poo passage bag, during your periods, you might notice, hey, every time I'm on my period, passing stool is terrible. It may be endometriosis. And the only way to confirm that is to do a camera test. Just passing a camera through the belly button, taking a look, taking a pinch if they see anything, and sending it to test. That's the only way we could tell. We can suspect and start treatment on it, hormonal treatment, because we remember the cycle. So if we can control the cycle, we could control. And if it doesn't work, well, then we may have to look at putting the camera inside. Huh? Yeah. No absolutes, but a lot of persons who come in with infertility, endometriosis is a cause. Well, I could only go with that if they had a confirmatory test. They could suspect it. It could be something else. Well, right. So if that's what they say, well then yeah. Because infertility is another topic, and there are plenty different things that could cause it. But so far we saw fibroids and endometriosis could contribute to infertility. Yeah. Right. So it's a benign condition, non-cancerous, where the endometrial tissue goes into the muscle wall of the uterus. It could cause painful periods, heavy periods. 1 in 10 women would have this. And for those women who have it, 70 out of the 100 women who have adenomyosis will have fibroids. 24 out of 100 women who have adenomyosis will also have endometriosis. So, right, but an ultrasound could pick it up and further investigation, if needed, could be done. Right, so the symptoms: severe cramps during the period, infertility, the womb becoming large. Just imagine you're having a period in a place that cannot shed because it's inside your muscle layer, the muscle of the womb. Your womb could become bulky, it could become large. Vaginal bleeding between periods, maybe some may ooze through and come out when you finish a period. The lining is gone, but you still have blood inside the muscle. It's just trickling out haphazardly. Abnormal or heavy menstrual flow, chronic pelvic pain, because it is there trying to come out. Pain during intercourse, longer menstrual cycles than normal because of this bleeding collection. Yeah. It could be one of the reasons, but there are other reasons that could contribute to that too, like having periods, prolonged periods. It could contribute to that, but it could be other things. It could be hormonal imbalances. For some women who have irregular periods, they might have periods twice a year, And when they have it that time, it might be long because it's building up over time, and it may take a while to come out. So there are different reasons, but yeah, it could contribute to it. But to say definitively this alone, no. All right, so hormonal influences, again, estrogen dependent. Why? Estrogen builds up the lining, right? With symptoms often worsening until menopause. That's when the estrogen and the other hormone goes away. Previous surgeries, procedures like cesarean sections or removing the fibroid may increase the risk. Genetic factors could be a hereditary component. Management. Again, medical. We could use, you all heard of Ponstan Fort? Yeah. So that is one of the tools we use. It could be used for painful periods, but it is also used for heavy periods. So a lot of persons would use it for the pain, but we tend to use it, yes, for pain, but also to reduce the amount of blood loss in a menstrual cycle. It cuts it down by about 40%. Right? So that's an advantage. But it doesn't work immediately. You have to start day one and continue it until the end of the period. And once you see like 2 cycles, and it will only, once you start it, because it's non-hormonal, you have to stay on it until you get something more permanent. Huh? It's 500. How the tablets has come? 3 times a day. 3 times a day for however long. And so we use that. That's one of the tools. Non-hormonal, the next non-hormonal, and this will work for fibroids as well. Anything that's causing heavy bleeding. Tranexamic acid, heard of that? Yeah. So Ponstan, the name is mefenamic acid, and the next one is tranexamic acid. We call it MATA, M-A-T-A. So once you're on that, once you're on that, we try not to get attention, otherwise you will cry. Gotta focus. So, right, so once you're on that, it tends to work. We start with that first, non-hormonal option. Then we go on to hormonal option. Of course, you have to qualify for that. What do we mean by qualify? We have to be able to use it safely. There are some women in whom we can't use it safely. For example, a body mass index over 40, anyone who is smoking, high blood pressure, uncontrolled. There's a list of things where we look and we see whether the benefits, where the risks outweigh the benefits, and then we say you don't qualify. But birth control pill is a good tool in the arsenal. And we spoke about the UAE and then surgery. We don't tend to surgically correct adenomyosis. Why? Because I will be shaving of the lining of the womb. And then that is embedded inside the womb. There are other procedures what we call ablation, where we burn it. We tend to use that for persons who had heavy bleeding, but not with adenomyosis, because how much you're going to burn, how deep is it going? So, all right, common medications. I saw this in the list, but I didn't understand. So, I said over-the-counter drugs and prescription drugs.
What would you recommend is safe and not safe to use, especially as Black women with these type of issues?
All right, well, so far I think we mentioned the non-hormonal forms. That's the mefenamic acid, tranexamic acid, safe, non-hormonal. Every medication has its side effect. Nausea and vomiting is more common for those two. The tranexamic acid, this is this drug stops clots from breaking down. So if you ever had a blood clot before, some persons have DVT, a clot in the leg or pulmonary embolism, we will avoid this. All right? Not to say that you can't take it, and if you take it, you're going to get a blood clot for someone who did not have. But if we see in risks, you have certain risk factors, we will just avoid it in total. And because this is only being done for short duration, 5 days every month, we use it. So, safe, right? In the right person. So the birth control pill, I talked about for those who qualify and for those who don't qualify. If you do qualify and you are offered this, common reason that women give for stopping the birth control pill is irregular spotting. Since I taken this, I only bleed. So you have to give it. You have to give it some time to work. Give at least 3 cycles, 3 periods, because if we're using it for abnormal bleeding, this is not for contraception. Contraception after 7 days, it's good, it's working. But for abnormal bleeding, the reason for the abnormal bleeding more than likely is some hormonal imbalance. And I compare it to a wave. So if the wave is moving all over the place, like Toko is not regular, and you want it to come nice and regular like this, which is what we see in the picture. The hormones in the pills are given such that they regulate. Once you take it as it is, that is the wave that you're going to get. It will take some time for the Toko waters to match up and line up and synchronize with that. And then in the majority of women, now this may not be a long term, so we give you a trial of 3 months, and we expect that after 3 months it cycles and it matches the wave, and then we stop it, hoping that just like a surfer or somebody on a surfboard, they will just ride this wave continually. Right? So that's the thought process as to how the birth control pill will work, but you have to give it some time to work. 3 months. I explained that all right? All right, good. All right, so, and then another thing, weight gain. A lot of persons, for obvious reasons, are concerned with the weight gain. The weight gain with these newer birth control pills is unlikely. It's more so now with the newer ones. You see the weight gain with the injectables. Those 3 monthlies Depo-Provera shots, you tend to see the weight gain, and that is about 5 kilograms on average. That's about 10 pounds over a year or 2 years. So with lifestyle changes, keeping in mind we're getting older, the metabolic rate dropping, we had to do changes. Yeah. It's been out a while. The question was, there's an implant that's placed in the arm. The question was whether it is new or whether it's been around for quite some time. It's been around for about 10 years. 10 years, yeah.
Is it common to be used among women who recently have babies?
Yeah. You can put that in as soon as you make baby. Like, so we do counseling for, we're going off on a tangent. So we do counseling for persons who, like I say, 8 pregnancy, nothing wrong with that, but, and every time is, because you always ask, is it a plan or it's, No, we don't. No, we don't advise that. No, because that's a surgery is last when all else fails. And in terms,
But then this is, that is last for 3 years, isn't it? For 3 years?
yeah.
Why I do it because recently I don't know about it.
Yeah, it lasted 3 years. So, right, for contraception, great. That's actually the most effective contraceptive option, better than tying tubes, better than coil, better than birth control pill, better than everything. Better than vasectomy. That's the most effective one. What? No. We're trying to avoid surgeries. We're trying to avoid surgeries. So none, no, because that has progesterone, a type of progesterone for women.
No, I don't know anything about it, so that's why.
Yeah. But so even though it has the progesterone, it is not used for heavy bleeding. Right? Why? Because this heavy bleeding, the abnormal bleeding, while it settles into the system, it could be heavy, and a person is coming to you for help because of the heavy bleeding. So it is not recommended for that, but in terms of contraception, it's very difficult to take out, but yeah, because the body forms tissue, scar tissue around it, and it's like, but if a woman wants it, you have to do a counseling. So you started off with tying the tubes. If they come and say, Doc, I want to tie the tubes, you're like, okay, I acknowledge your concern. Have you explored other options? And they have to make sure that they are well informed about all the other options first. And if they are aware and they say, okay, I hear what you're saying, I still want my tubes tied, then I will respect her decision and we go tie her tubes. But she has to be aware of these other options. And most of the time, after proper counseling, they take another non-surgical option. Nobody want to do a surgery, especially when something more effective is there. Because even though you tie your tubes, 1 in 200 women are going to get pregnant.
Have you had any problems with it with women? You can't find it.
Right? So the question is the implant in the hand. The question is with the implant, if they have any problems with it, in terms of if it's lost and they can't find it, yes. Yeah, yeah. No, I mean, we find it. But you have to go for x-ray, and it's like, oh, look at there. And then it all depends on, because, and it's not, it could be someone who has, thick hands, or it could be someone who has some hands. Sometimes it's hard to find. Yeah, we respect a person's rights to choose, and if you want it, cool. And we put it in and we'll take it out. But for me, like personally, it's like 2 in 10, I had a fight up, like looking for it or kind of thing. For other persons, it might be more, but it works well. Okay. So, birth control pill, I mean, once you qualify for it, great. The matter we spoke about, the intrauterine system, that's the Mirena coil. That is the first line treatment for heavy bleeding. So for someone who's having heavy periods, first line treatment is putting in the coil. If you have large fibroids that will distort the lining of the womb, then it may fall out, but you'll be assessed to see if you would qualify for that. And then you have the injectables every 3 months. And then you have the one, this GnRH. This is an injection. Some persons come in asking if there's anything that could be done to shrink the fibroids. And I think that this is a question that this is the medication they're talking about. So yes, there is something that could shrink the fibroids temporarily, right? This is a hormone. You get it monthly, and it shrinks the fibroid by about 30%. You cannot use this medication for more than 6 months because how it works, it will put you into a chemically induced menopause. So for a young person, these hormones, estrogen and progesterone, are necessary, not just to get your periods, but for health. That's a protective hormone. So putting you into that state past 6 months increases risks of certain things. So we don't do it past that. And once you come off of it, it's going to grow back. So sometimes to make surgery easier, we may choose someone, if it's large and we expect problems, to have this for a few months before to shrink it down a little bit, to make the surgery a bit easier for us, right? But that's another medication. So long term, no, there's nothing that will shrink the fibroids permanently. Short term, yes, there's something that will shrink the fibroids temporarily. Right. So yeah, this year is looking at contraception, but we're not talking contraception here, we're talking heavy bleeding. So this is the implant we spoke about, but we're not using this for the heavy bleeding. But this is the most effective. This is probably the third effective. The coil with the hormones, and then the copper coil, which could last for 10 years under that. And then you have the pill, the patch, injectables, and we're not talking about anything here. All right, so we okay with heavy bleeding? Yeah? Right. So we're going into the menopause now. Over the age of 45 years of age who have not had a period for 12 months, not using any hormones because the hormones can mask it, that's when you are sent to have gone through the menopause. At this point, the ovaries stop releasing eggs. It also stops releasing hormones, estrogen and progesterone. The perimenopause is that time approaching the menopause, where you're still having your periods. They may become irregular, but you're getting the symptoms. We'll talk a bit about the symptoms, or you could correct my slide if you see anything else that I missed out. And the perimenopause ends, and you reach the menopause when you have not had a period for 12 months. And we'll talk about, this is an important topic, because in the perimenopause, we don't want women to be saying, oh, well, I'm going through the perimenopause and this bleeding is normal. There are certain types of bleeding that you must be investigated for, because there is a chance of some abnormal cells, which could be precancerous, or it could be cancerous, and we don't want anyone to say, oh, well, I'm just going through the menopause, right? So we'll talk about it. Right, so the menopause and the perimenopause symptoms could have a big impact on the lives of women, including relationships and work. That's correct? Yeah. Cessation of ovarian production of estrogen and progesterone. But the symptoms that you will feel would be more estrogen related, which is why hormone replacement therapy would work how it works. It's an option. We'll talk about it. So there are some questions here, like for the person, how will you know if someone went into the menopause if they had a hysterectomy? Well, we look at the symptoms that they're having. More than likely, this person may have left the ovaries. If it's a younger person, like say they're 32 and they left the ovaries, so there's no womb, there are no periods. So we look at the symptoms, and then there are certain tests that we could do. What about the woman under 40 in whom we suspect menopause? This is a condition called premature ovarian failure, which could happen in about 10% of women, where you are less than 30 and unfortunately you're going to the menopause. And what about the woman 40 to 45 with menopausal symptoms? So we do certain lab tests for that category of women. This slide is just for women who over the age of 45, right? So we use this test called the FSH for women in whom we suspect, or someone who is using, let's say, for example, you have a Mirena inside, and you are 52 years old. It would be hard because the Mirena in the majority of women would not cause any periods at all, and you would not have had periods for about 7 years. And now you are 52, and we're not sure if you're in the menopause. We can use this blood test here. All right, we do it 2 times. So one test, high values, we repeat it. If it's still high, then we can say, okay, you went into the menopause. So the symptoms, hot flushes, yeah? night sweats, joint muscle pain, serious, dryness, vaginal dryness, mood changes. It wasn't the same. And then decreased libido. And everyone is different. Some women don't have it. Some women have it. And not all. Some, it may be brief, it may be long, and it may be severe, it may be life-changing, relationship-changing. So which is why it's important. I was hoping more men could have come. We'll get them next time. We'll get them next time. All right? So what could we do? Does this work for the low mood? Getting rest, exercise, relaxing activities. I know we have a psychologist amongst us here, cognitive behavior therapy. I know. Could this? How you have experience with it? With the CBT, right? Has it, in your experience, helped? You saw anyone come in for like menopausal symptoms? That's not listening to the mic. Listen.
Yes, yes, Dr. Charles.
Ryan is fine.
Yes, Ryan. So I have had clients come and I would send them to the doctor because I believe that what they came with was menopausal, perimenopausal related and not strictly psychological.
Oh.
And so that's how it has worked for me. So I haven't had anybody come to do CBT because of the menopause per se, but if they go to the doctor and they get the help that they need, then we could counsel them on whatever else may be an issue. But a lot of things are resolved
There.
from meds and exercise and that sort of thing.
All right. I asked that because ideally it's supposed to be like a joint, a team. So they're supposed to accept the referral and then continue joint management because everything will work together. We're trying to get these ladies the best outcome. And there's a role for CBT. But we'll see.
Yeah, that's how it's worked for me so far, but I don't know if other persons would have had the dual.
Yeah.
Right, because it's supposed to be, I know that which of course I can't remember the rest of the word because of the brain fog.
Multidisciplinary team approach.
Multidisciplinary team approach, you see? Yeah. All right, thank you.
All right, well, thanks. Right, so this is a type of talk therapy that will help with the anxiety of approaching. Sorry, question?
Okay, I I heard of all the changes that the women go through during this period, this menopause period. Now I wonder how do we prepare our men to deal with all these different changes.
That's a good question. Yeah. Well, we younger men have to take experience from the older heads. So you all have to be guiding us. Yeah, but ideally we should have had more men here. It would have been fun. It would have been nice. But for now we had to take follow from you all. You all had to tell us.
Sorry to be so.
Yeah. All right. So, other conservative measures for the hot flushes and night sweats, wearing light clothing, keeping your bedroom cool at night, taking a cool shower before you sleep, using a fan, having a cold drink, trying to reduce your stress levels, avoiding triggers, spicy food, caffeine, hot drinks, smoking, alcohol, exercise, weight loss, and we mentioned CBT as well here. The vaginal dryness. Normal over-the-counter water-based moisturizers, they help, but the estrogen, this is important, the estrogen keeps the lining of the vagina thick, healthy. So when it is removed in the menopause, it gets thin. So sometimes a woman might come in with what we call post-menopausal bleeding, which is serious. And after investigation, because we have to rule out worst case scenario first, before we say, oh, it's just this. But the most common cause of the bleeding would be dry vagina, a condition we call atrophic vaginitis. And then we can use an estrogen-based cream that you can just use to wipe on the inside just for a few days, and as needed thereafter. And it doesn't increase the risk of, like some persons have concerns with HRT, hormone replacement therapy, but because this cream just works in the area of the vagina, the amount that goes off into the system is minimal, so you don't have to worry about all those side effects. And it will help with that vaginal dryness. So over the counter, KY jelly, and then if needed, estrogen-based creams. Important to protect your bones. Yeah, so osteoporosis, if you notice a lot of older women, they were taller, if you remember, and then it feels like they're shrinking. Depends on the extent of the osteoporosis, if any at all. So building the muscles around the bone, so any weight-bearing exercise could help reduce the chance of that. Walking, running, I would cut down depending on the age and the joint pain, because I already saw that that's a symptom. So dancing, resistance exercises, healthy diet, sunlight, vitamin D supplements. Everybody should be taking vitamin D supplements, right? They have the caltrate D, so you're getting calcium and vitamin D. Everybody should be taking that who went through the menopause. And well, if you're smoking, stop that, cut down on the alcohol. All right? But very, very, very important, because in a certain age group in the menopausal woman, fractures, you don't want to get a fracture. All right? Fractures decrease life expectancy. All right? They actually had studies, fractures based from osteoporosis decrease your life expectancy significantly. So like the Christmas cleaning and thing, have the grandchildren go up on the ladder or something. No, I have to tell, I just had to speak to mommy. I'll be like, you can't be going up on the ladder. So you don't want a fracture. Protect the bones. Medical management. So we have the hormone replacement therapy. Different types. We have the tablets, and they have patches. So depending on the symptoms, some women rather just go through natural, and it might be short, it might be long, but everybody is different, and there are options. You don't have to fight it out. So there are the estrogen-based ones. Now, it all depends on what you're having. So if you are perimenopausal and having symptoms, perimenopausal meaning symptoms, but you're still bleeding, then there's a special type of hormone replacement therapy to facilitate the fact that you're still bleeding. It's called a sequential type. If you're already going through the menopause, no bleeding, then you could take it continuously. All right? Now, some women will have a womb, some women will not have a womb, whether they had a surgery or something before. So if you don't have a womb, you can safely take the estrogen. But if you have a womb, you can't take estrogen alone, because this will build up the lining of the womb, increasing your chances of getting womb cancer. So you need to have a balance of progesterone. So for persons who have a womb, and they determine that you need to have hormone replacement therapy, they will give you estrogen, but they'll give you some form of progesterone. Some people will prefer the insert because you could just put that in and forget about that. Well, for five years. But take your HRT estrogen tablets, or you could take the progesterone tablets. It all depends on what, after a conversation with your gynecologist, what you choose. And the side effects profile now, the major side effects, and it all depends on the age, will be blood clots, right? The patches could be used to reduce the chance of the blood clots. So let's say someone is at a high risk of developing blood clots. They'll say, okay, here what? We're not going to give you the tablets, we'll give you the patch. And then you're back down to baseline. So you can still benefit from it. It's not like you can't use it. And then heart, because the blood clots, cancer, breast cancer, that's the next one. As we all get older, the baseline risk of breast cancer is 1 in 12 women will get it, unfortunately. So the risk, depending on when you start the HRT and for how long you take it, that will determine the risk. But the risk increases there, but it is a small increase. So if you just want it for a few years and you're still doing your breast screening, which everyone should be doing, then you can use it. So it's not an absolute, unless you have a history of having had breast cancer, then you want to avoid estrogen totally. Any hormone you want to avoid totally. Okay? Right. So recently, yeah. So there are a few herbal medications that have been studied. One of them would be for men, the sour palmetto, and that for the prostate. That has been studied where you could say, we saw that there's a 5% risk reduction in prostate cancer. I just threw out a number. They can't say that for evening. No, for what? No, that I using an example, but for evening primrose, because I used to suggest that too until I saw a few years ago that the evidence not strong enough. They have more evidence for this black cohosh, and I saw it in this pharmacy where they sell those supplements. Again, I can't comment. I mean, the evidence is not strong for us to say, okay, you could make the recommendation. So I can't make the recommendation, but there's some evidence that this works. Right? The menopause. I guess it's possible, because remember how we were saying you have central release of hormones from the ovaries, and then you have peripheral release in the fatty tissue. Not everybody have fat, everybody. It all starts with cholesterol, and cholesterol makes male hormones, female hormones. So it's possible. But because it's not something that you'll commonly see, because it could be another condition. There's a condition called hirsutism, where there's an imbalance for whatever reason, more male hormones, and you have that presentation. We'll talk a little bit more about polycystic ovarian syndrome, and that's one of the conditions where there is a little imbalance in the hormones. But with respect to the menopause, it's possible because you still have your peripheral release of hormones, which could become anything. Right? Not enough of the estrogen that you need, because there are different types of estrogen. That becomes E1, inside here is E2, and E3 when you're pregnant. So it could become a male hormone, which we all need, well, women, some levels. Cognitive behavior therapy, testosterone supplementation. Now, this is something for women who have a decreased sex drive. It is something that is used to boost it. Vaginal estrogen, we mentioned that before, and then we talked about the herbal options, which I can't comment too much on. Right? We spoke about the concerns with the HRT. It all, again, depends on the type. If it is a continuous, you have gone through the menopause, you're not supposed to be bleeding, we could watch it for 3 months before we intervene. As opposed to the other one where you're supposed to be bleeding, we can watch it for 6 months before we intervene. Blood clots, we mentioned that. Heart disease and stroke. Breast cancer, we mentioned that. Diabetes, no strong risk. HRT improves, not improves osteoporosis because you can't reverse that, but it reduces your chance of moving from osteopenia, which is just before osteoporosis, to osteoporosis, right? Right. This, of all that talk we talk, this is the most important thing. If you went through the menopause and you have any bleeding, even if it's spotting, go and check it out, right? Any bleeding is not normal. It could be more than likely something that's non-cancerous, but go and check it out, right? Because you don't know and you cannot sit down on something. Right, so we moved from the womb. That's a long time. Question was, if you had a hysterectomy, does that put you directly into menopause? It depends on the age, 1. 2, it depends on if the ovaries were conserved. Was this hysterectomy done with retention of the ovaries? The ovaries were left, the ovaries were taken out. Well, then that's immediate menopause. Immediate menopause. Yeah? Which the person in whom that was done should have been counseled about that, to expect that. I just see it. I have a question there.
Okay, so if you haven't seen your period for about 3 months now, would that be heading into menopause state, or you have to wait a whole, you have to be over a year to know that you're in menopause?
You have to be over a year. But how old is this person we're talking about? We're talking, we just, I don't need to. She's 45. All right, so we had to look at other things too, right? We had to look at, because it could be polycystic ovaries, polycystic ovarian syndrome, which we're going to talk about just now, before we say that. But are you getting symptoms? Hot flashes and all that? Okay. Okay. Well, together with that, and going back to the line that I skipped out, I should have left it. So without laboratory tests in otherwise healthy women, age over 45 years. So once you had your 45th birthday, you're 45 and a day, so you're over 45. With menopausal symptoms, perimenopause based on symptoms and irregular periods. Menopause in women who have not had a period for 12 months and are not using contraception based on symptoms without a uterus. So that young lady would be in this first line here. Provided that there are no other medical problems in that young lady.
Why do you want to hear me? I experienced the symptoms with not sleeping, a lot of joint pain, highest level, and I started to use the evening Primrose.
It helping?
It did.
Okay.
Trust me, it did.
Okay.
Because
If
with
it
the
working,
anxiety,
continue.
it had me to Point Hospital because I had, what do you call it? Palpitation to the highest level. So
they check out the heart and think one
everything
time.
was good. Everything was good. So
You did any ultrasound of the tummy by chance?
no, I didn't do an ultrasound of the stomach, but I did ultrasound of the heart and everything else. But everything came back normal. Blood tests, everything came back normal. So just that, and after I started taking the evening Primrose, everything came back down to normal. So how I was feeling before,
Evening Primrose?
it did work for me. I don't know
Okay.
for anybody else, but it did work for me.
Well, whatever works. Whatever, yeah. Once it's not causing harm, fix up.
Yeah.
Question.
I put in the loop, right?
Which
No,
one? The one with the
the-
hormone or the one without the hormone?
I don't know which one. They
You
didn't
use it
explain that
for contraception or for bleeding?
to stop the bleeding.
The one with the hormone.
Right. So
That's a good one. Yeah.
so now oh yeah. So when they did that, I think after a couple of it's only about 2 years now I did that. 2022, 2024. 3. So when for this year, 3 periods. Not, they say, well, it wasn't to bleed with it or...
You got that in the public system?
Yeah, right, in general. But you was right there.
Me?
Right there. Right there. You was outside. Because, no, you were out there.
So you got a little paper, it was a pink paper?
Yeah, we
because
got everything.
I'm asking because there's, at some time we had a shortage and they were giving a 3-year one. But I know the one,
No,
the
I
pink
didn't
one
get
is the 5-year one.
I get the 5 years. So what I'm saying is...
You were having no periods for
no
2 years.
period for that 2 years.
And then you get
look,
3?
This year, I come and I get
But
3 periods.
But is it, it's like 2 days and it's spotting?
2? Like,
How long it lasts?
it lasts in a little while. Because look, I get one for this month already here. With a little pain around the area. And they dismiss me. They dismiss me from the clinic. Yeah, they dismiss me from the clinic.
We could talk after. You're not supposed to discharge anybody who has a coil, and you're supposed to see them every year until we change it. Either take it out or change it. We could talk. Don't let me leave, right? Right, sorry. So, any other questions? No? No, good. Right, so we're in the ovary. Right, so again, we're doing a little anatomy. That's your ovary. So what's supposed to happen? We saw, if you remember, the hormones and the build-up of the lining of the womb and everything. One of the areas, it would select what we call a follicle. This follicle will grow throughout your cycle, and then halfway through your cycle, you have your ovulation. It releases the egg and it goes up into the tube. And and it goes to meat or not sperm. What remains here would be a cyst. This on average is this corpus luteal cyst is about 2 centimeters, and it's just a fluid-filled sac that would release progesterone to keep the lining of the womb thick in case a pregnancy happens. So after your ovaries, the substance of the ovaries, because right now it's low, you want to maintain it. You don't want to have a period if there's implantation. So this will stay here until the implantation occurs, and then the natural embryo, the baby could take over to sustain itself. And if pregnancy doesn't happen, then this will degenerate and we start all over. I say all this to say sometimes you have no ovulation occurring. Imagine someone who's trying to get pregnant. You're doing a test to see, first off, are you ovulating or not? And it just backs up and collects, and then you have all around the rim of the ovary, you just have these fluid-filled sacs. This together with, so this is a condition called polycystic ovaries. Not to be confused with polycystic ovarian syndrome. So you have polycystic ovaries based on what we see here, so we're going forward. So the cysts could be normal, what we call physiological cysts, which is what we saw just now, which after 3 periods, it goes away. So let me say you find out you had a cyst, and it is a simple cyst. It doesn't have any suspicious features. We say, okay, it's less than 5 centimeters. That's going to go away on its own. Or a cyst could be problematic. Let's say it's a bit larger. It could still be simple. This cyst could either get even bigger, it could burst, or it could shrink. Let's say it's a cyst that has, within the features, it's not just fluid. It could be solid components. There are certain features that they look for to make that cyst suspicious. Right? And again, it can cause symptoms. It can have mass effects. We've seen cysts that are like fibroids, big like babies. The cyst could burst. If it bursts, it releases a lot of fluid, which will irritate the lining of your tummy, which causes excruciating pain. Sometimes women will come in with sudden onset tummy pain, worst pain, they say. After you do an ultrasound, you see polycystic ovaries or a few cysts, and then you see a little fluid inside the tummy. So the working thought is that you had a cyst that burst, causing this pain. We do pain management, and the body will absorb the fluid. Right? And then we see them back in clinic to talk about a plan. And any features, any cysts that will have any suspicious features, depending on your age, certain tumor markers will be done. All right? If you are menopausal and you're seeing cysts, we take cysts in the menopausal woman seriously, because you're not supposed to be having any cysts, because you're not supposed to have any hormones. So then that means it may be something that is growing that could be sinister, right? So that will need investigation. Again, we have tumor markers before we intervene that work very, very well to help us streamline persons as high risk and low risk. Right, so red flag symptoms: pelvic pain, persistent, sudden onset, sharp, on one side. Bloating or fullness. Sometimes the cyst, or even just the presence of the cyst, could make you feel, you eat a little bit and then you feel full. Your tummy feels full. That is a red flag sign that needs investigating too. All right? Irregular periods. Changes in the flow, missing periods or spotting, pain during intercourse, frequent urination or bowel changes, depending on where it's pressing against, and well, severe symptoms, intense pain, dizziness, nausea, loss of consciousness, because a cyst that is over 5 centimeters, if it doesn't burst, it could do like the mango we talked about. It can twist upon itself, stopping the blood flow to that, letting it become what we call necrotic, and that's excruciating pain. And if it's not relieved timely, if that twist is not relieved timely, then that ovary could be lost, right? Because of the lack of blood flow for however long. So we saw what polycystic ovaries look like. Polycystic ovarian syndrome is where, yes, you have these cysts, but then you have one of two other things. The periods could be irregular, and/or you could have signs of elevated male hormone. So this will be the facial hair, the male pattern baldness, or deepening of the voice, right? When you have the ovaries, the polycystic ovaries, and any one of these two, then that would be polycystic ovarian syndrome. For a girl who is less than 20 years, an adolescent, she needs 3 out of what we just spoke about. Instead of 2 out of 3, she would need 3 out of 3 to have that diagnosis. Okay? It's associated, it's a common condition in which a hormone imbalance causes irregular periods, increased hair and acne, and may affect fertility. But you can still get pregnant, but it just may be difficult. It's associated with obesity and increased insulin resistance, and therefore increases the risk of developing diabetes later on, heart disease, and other conditions in life. So anyone who has polycystic ovarian syndrome should be in a clinic. I know before we used to discharge, but now we have to keep and see at least once a year because of the other risks. We have to screen for diabetes if you don't already have it, as well as any other heart problem. So women with polycystic ovarian syndrome can reduce the risk of long-term health problems by having a healthy lifestyle and maintaining normal body weight. What causes? Not known, sometimes run in families, sometimes not. Sometimes just one person will have it. The symptoms are related to abnormal hormone levels. One, we see the testosterone. In this area, it will be a little higher than normal. All women supposed to have some amount of testosterone. Is here where it is higher than the normal woman range, where it will become problematic, and we see male type changes. Insulin. Have you heard of insulin resistance before? Right? So, polycystic ovarian syndrome is related to insulin. It increases the insulin resistance. And on your muscles. So the whole point of insulin is to bring, so you eat food, the food goes in your tummy. The body, the intestines absorb it. It breaks it down into different things. One of the things, the main thing, is the fuel for the cells, which is glucose. Your body wants glucose. On certain parts of your body, particularly the muscles, what we call the skeletal muscles. This is like the muscles here. Muscles that you could control. There are gateways. On the gateways, it's like a gate. There's a lock. And on that lock, the insulin has to go and get into that lock to open up that gateway so the circulating sugar in your blood, glucose, could get into the cell and we could use it, right? Which is why they say diabetes is a disease of starvation. It's because the sugar stays in your blood cells, in your blood vessels, sorry. It can't get into the cell. So when you check your blood, the sugar high, because it can't come out from the vessels to go in because of that. Either the lock not working, You don't have enough of the key, the insulin, or the key not looking like the right key. So either one of these or all of these three things could be happening, and that's insulin resistance. So to beat insulin resistance, increasing muscle mass, I'm spending time on this because that's a treatment for this, right? Increasing muscle mass would make the lock better, increase the number of locks. You might have plenty locks instead of one. So you would be able to become insulin sensitive, which is what you want for polycystic ovarian syndrome, right? So I hope I explained that. Kind of confusing, no? All right, good. How you increase your muscle mass? Resistance training. You don't have to turn into Superman, but no, but any little thing, whatever, 2 weeks ago, whatever little 5 pound, a little the water, the 500 ml bottle, just any move in that direction, because your muscles are hungry, they want to eat. It don't have to be big muscles. All muscles, if you use it, it needs to, and it continues to work when you are sleeping as opposed to not working. So with age, when you're young, your metabolic rate high, right? You eat food, you're hungry in 2 hours. As you get older, the metabolic rate drops. So the machine not running as fast. So you want to slow down the rate of decline or even turn it a little bit. And in increasing or giving the muscles, whatever is there, something to do. You increase the receptors on the muscles for the insulin, that's the locks. And while you are not doing anything, sleeping, the muscles working to pull, to keep it working. So that's for everybody, men and women too, because we have the insulin resistance as well too. All right, so expect annual visits with, to rule out diabetes, heart problems, and womb issues. Having polycystic ovarian syndrome increases the risk of womb cancer as well. So we have to look at the thickness of the lining of the womb regularly, or ask certain questions. And remember, we were talking about the peripheral deposits. So the peripheral tissue making the estrogen and just pushing it there. Yeah, so we had to look at all these things with this condition. So the symptoms often come and go, particularly if the weight goes up and down, and this can make a difficult diagnosis, which means it might take a while. And we already went through any 2 of these 3 things for the older woman, and for the younger woman, 3 of these 3 things: irregular periods, increase in facial hair, ultrasound showing multiple cysts in the ovaries. So we know the difference. Just having polycystic ovaries and everything else okay, and having polycystic ovarian syndrome. Symptoms: irregular periods. Some women have no periods at all. It's important for women to have at least 3 to 4 periods a year. If you're not having that, then, and you're not in perimenopause, then we have to use medicines to bring down a period to reduce the risk of womb cancer. All right? So 3 to 4 periods a year, acceptable. Anything less than that, problematic. Unless you have the coil, unless you're in perimenopause, or you're using some other hormonal treatment that will interfere with your periods, right? Loss of hair, being overweight and experiencing rapid increase in risk of having difficulty in losing weight, oily skin or acne, difficulty in becoming pregnant, and the associated mental problems that would occur with any woman experiencing any of these problems. They may need additional help, psychological. Long-term risks, insulin resistance and diabetes. 2 out of 10 women will go on to have diabetes. Risk of high blood pressure and heart disease, cancer of the womb, aim to have at least 3 to 4 periods a year. Depression and mood swings, and snoring and daytime drowsiness, sleep apnea. Okay. We're on the ovaries. We finished the ovaries now. Any questions?
How effective is metformin for a woman with polycystic ovary?
Metformin in isolation or metformin after lifestyle changes, and then you top it up, because we're supposed to start, right? So how does metformin work? Metformin, they say, is an insulin sensitizer. It's supposed to reverse the insulin resistance. So it's like one tablet, or it's going up higher, right? I don't think it's that effective from what I see. In terms of treatment, it's more of polycystic. It has a place there, but its place is high up in the early parts. The main thing is, so we will advise any direction away from in weight loss, in terms of BMI, I know with having polycystic ovary syndrome going to make it hard to lose weight. But any direction away from where you started could, because remember what we were talking about in the early part, the tissue, any fatty tissue will change the cholesterol into estrogen, among other things. So that's how you'll have the thickening of the lining of the womb. That's how you'll have it's just building up and it's not being released. Normally coming back to the cycle here. This is staying high in these women. So it's not getting a chance to come down to reach to this point here where you have the release. It's not getting a chance to come down. So any direction away from that would help. And I've seen it help people. Yeah. The periods come back normal. Fertility, they come back pregnant. We see them in the antenatal clinic. And it's not even that much loss. To answer the question, I don't think metformin. And I'm saying this because I used to do pharmaceuticals before I did this medicine thing. And one of the medications we used to do was a medication for diabetes called Avandia. And that was made for insulin sensitivity, made for that. And yet, they did not bring it on, for whatever reason, into gynecology area. I don't know why. So, just on my observation, it doesn't help much. What is more effective is the lifestyle changes. All right, so we're on to the cervix. I think we're wrapping up soon. Right? So everyone here is getting their pap smears done, right? How often is it supposed to be done? Every year? Every 3 years. I mean, if you get it every 2 years, if it's me, I was doing it every year or every 2 years. And why I say that, because not many cancers have a screening tool like this. You have your colonoscopy for colon cancer every 5 years. You have your mammogram or your breast ultrasound for your breast cancer. You have your pap smear. 3 years. For the breast. Oh, no, I'm talking about the pap smears. The mammogram. Where? They're in the UK or in the... Right, they're different. But go ahead, go ahead. Mm. It's 1 to 2 years, so between the UK and the US, yeah. But yeah, get it done. Every year, just take time and just do your whole woman's thing. Make it a birthday gift or something. Go with your friends. And a lot, yeah, make a line, this time we meet enough for serious business. And at least, like, because the mammogram is available in the hospital. It's not as harsh as? I never had one. I'm joking. I don't know. In the hospital? Private? Well, yeah. But screening, well important. But in the public, you can get the mammograms done. And like if you put the machine always down, but if you put it in, for a year time, you have a whole year to wait for it to be up and get your date. Yes. I, okay, but to do that is important. Pap smears, because cervical cancer is such a slow-growing disease, and because of its location, where the cervix is deep inside, by the time you actually get problems, is pretty advanced. And the treatment, if you do regular pap smears, is just like a little pinch. The treatment is just to take off an area, and it's not a little pinch. No, is it? They numb the area 4 places. Some women experience some discomfort, but seriously, on weighing the pros against it, yeah. Because I am assuming you're talking about the LETs. Oh, no, the pap smear not supposed. Let me say this, sir. I know for some people it is. The pap smear is not supposed to be uncomfortable. I know. It depends. But it's not supposed to be. And a lot of persons don't go back for it because of that, because they had a bad experience and like, I ain't going through this again. Which is unfortunate, but understandable. But to do the pap smears, yes. Yeah, it's every 3 years, right? There's another test that it may be available privately called the HPV test, where you could just check for that, and that's 5 years. So once you're clear, they don't have to see you again for 5 years. But in the public, they still have the pap smears. HPV. Yeah, I'll go into the Asian just now. After a certain age? Yeah. So the question is, at what point you stop doing your pap smears? Right, so from the age of 24 or 3 years after your first sexual encounter, you start doing your pap smears. And you do it every 3 years up until the age of 50. When you're 50, you do it every 5 years. So you do it 55, 60, 65, and provided you have 3 negative ones, lock off. That is it. So 65. But that's provided you have 3, because you want to get to where you have 3. So you keep doing it until you get 3 negative ones, right? Right. The question is, should someone who had a hysterectomy do a pap smear? It depends on the type of hysterectomy. There are different types. So if you had a total hysterectomy and they looked at everything under the microscope, because sometimes when they look at everything under the microscope, they could say, hey, look, she have a precancer of the cervix there. Then you'd have to do, but before anybody would have discharged you, discharge a woman who had a hysterectomy, they would have gone through the report of what the microscope doctor. The public system? Nah, any public system. I will not say anything bad about the public system. It depends on the individual. Suppose it depends on it depends on whoever do it. No, it's much easier when you have a conversation. And from my experience, from those I've seen, it is easier where everybody on the same page. I will spend however much time it is to talk. So everybody on the same page. So when you leave comfortable, and I leave comfortable, so you can't say I ain't tell you. All right? And I've seen that in where we are. So I'm not negating your experience, but I haven't seen it. So provided that the report was clear, you don't have to do anything else. For some women, they just take the womb and leave the cervix in a subtotal hysterectomy. That woman would have to continue doing pap smears. Right? And then the woman who had a total hysterectomy, it all depends on what that final thing is. Because you won't have a cervix to smear, so they do vault smears. So they use the same pap smear kit, and they just do the part that's stitched, just to make sure. For a person who did a hysterectomy, a total hysterectomy, they don't need to do any pap smears, provided that when they look at the report was like, okay, everything is clear. They have no precancer or cancer. If they had a precancerous condition, then that woman may need to have a vault smear. That's a smear of the top of the vagina here, because all this is out, so it's just stitched across. So they just do a smear of this area. And for someone who had a subtotal hysterectomy, this is where they take off this part, and they just leave that for whatever reason. Sometimes it's a difficult surgery where the chance of the bladder being injured is high. They say, okay, it's best we just leave this part. This woman in whom it is left would require pap smears as the normal routine, whatever she was on. Yeah? For pap smears, every 3 years up until the age of 55, up until 65. For 3 negatives and then lock off. Right, so for anyone who has daughters, granddaughters, there's this HPV vaccine. So the necessary cause of cervical cancer is HPV. That's a virus, sexually transmissible, but it's common. Once you become sexually active, more than likely you will get, more than likely. Your body clears it from the system. It is the persistent infection together with other risk factors which will affect your immune system, like smoking, high-risk activity, or immune suppressing medication, like let's say you have to take steroids for whatever reason. There are persons who have to take that. Then it is the persistent infection of this HPV that will lead to the development of cervical cancer. There are 200 different types of HPV. About 20 of them are cancerous. There's a vaccine that is available, that is free. In private, it's like $3,000. It is free in the public sector for young girls. this will reduce significantly, 90%, their chance of ever seeing cervical cancer. We recommend it. Right, so in Trinidad, we're still using the 2, but since this is about 20 years abroad, they've been doing it, so they have more research. We introduced it 10 years now or something. And the uptake was low for whatever reason. Can't understand. If there was a vaccine for prostate cancer, I take that in the morning. But no, if there's a vaccine that reduces your chance of having cancer, like 90%, I think that is kind of, but we respect. No, it's part of the National Schools Program. My daughter, the older one, she is of that age where they came to the school and they offered Standard 5. Yeah, yeah, that is, yeah, it is talk to your family, whoever, who could access it, up to 25, yeah, 25 or something. If you're willing to pay for it, you could go up to 40 something, provided you're negative for HPV. But I mean, 25 is fine. But right now, to answer your question, is 1 injection outside, but they have not translated that to here. Because they find out that with 1 injection, they're having the same immune response protection as 2. They started off at 3. They went down to 2. We are 2 here, but we kind of waiting. So it's really 1 out there.
So how often would you have to take it at the same time?
No, 1 and then I think it's a month after. I can't remember. Something nearby. And you covered. If you miss. You will have to get it 2. That's what the new study is. You mean to start over? Like you get 1 injection? Right. I can't answer that. But what I have, I could talk about my experience. This is not, take off that record. But, so like one of the, I think I had to get some vaccine. I think it was hepatitis or something. I forget, yeah, so I start over. so, or if I lose a paper, I shouldn't say that out loud. Start over. Yeah. So, but get it done. All right, so that's pap smears. But even if you have the vaccine, you have to still, it's risk reduction, it's not risk elimination. Still continue your pap smears. For girls aged 12 to 13, they say that's the point at which you get the highest immune response to push out all the antibodies that will help fight. Right? And it doesn't just work for that, but you ever saw genital warts? It protects that type of HPV as well, so, and even higher than the 90%, so that should be gone. I have a question, sorry. Yeah. Somebody who's the age of 22. Yeah. Check in the health center. It's supposed to be up to 24. Yeah, but they may have stipulations. Everybody. But 24, I mean, you'll have to get the 2 shots. The new thing that is translated, not yet translated, is for 1 shot for the younger population with a bigger immune response. But for somebody who missed that initial catchment time, they'll have to take the 2. I mean, 2 injections to protect. That's good. All right. Right, so an English study, so they have this about 20 years now. It showed that the vaccine dramatically reduced cervical cancer rates by about 90% in women in their 20s who were offered it, age 12 to 13. Although the vaccine protects against the 2 types, it's now 4 types that cause most of the cases of cervical cancer. It doesn't protect against other types. But, like I said, there are 200. There are similarities in those types with others. So instead of 90%, it might cover 45% of the other ones as well. So you get some level of cross protection. All right? So continue doing your pap smears. We talked about this. This is the procedure. You all should be familiar with it. Who has to be screened? Women. Now we have to include trans men, non-binary persons from 25 to 64, 3 yearly, and then 5 yearly. Okay? HPV testing. This is available privately, but this is the way forward because it tells you you can't have or get cervical cancer if you don't have HPV, which is why they say, and its keywords must be used, the necessary cause of cervical cancer is persistent infection. That means infection that your body is not clearing by HPV. So they're doing the HPV testing. Once it's cleared, they say, okay, that's it. Say in 5 years. Inclusive of screening. Right. So for anyone who is not up to date with their pap smears, as in every 3 years, any abnormal bleeding, especially bleeding in between your periods, should be investigated. Any abnormal bleeding, especially where there's trauma after intercourse, post-coital bleed, we call it, should be investigated. No, that should be your trigger to go and get a pap smear. Any abnormal discharge, it smells, it's a distinct smell. Go and check it out. All right? Or painful intercourse. All right? Screening is all over. Right? I think we did good time. Yeah? We did good time. Any questions? No? Any other topic you want? Yes.
Yes, I heard something earlier this week that was interesting, and I wanted some clarity on it. They were saying that as women get older, they get an increased number of UTIs, urinary tract infection, I think that, right? And out of that, people end up being hospitalized. And I wanted to understand how that happens. And they're saying that, I think they were saying 60 and over. And I wanted some clarity on if that is true for us, and how do you prevent that from occurring?
No, I don't. I mean, there are conditions that will come up in the older population, and that will come into we were talking about it before, urinary incontinence, the different types. This is where you have problems keeping up your pee. In the postmenopausal woman, one of the symptoms that wasn't mentioned here is the urinary incontinence. Why? Because you're seeing where how the estrogen works on the lining of the womb, and I was mentioning how it keeps it thick. You can see the close proximity of the vaginal wall, the front part, to where the pee-pee places. So they have urinary problems, but I won't say the age increases the chance of urinary tract infection. I would say the age increases the chance of urinary incontinence. because you could have urinary incontinence and not have any UTI, right? So it's not a statement that should have been made. No, it's probably related because they have other things going on. I don't know. I didn't answer your question. Yeah, but no, I won't say that. What has been the experience of anyone here? Any increase? You noticing any increased burning passing urine after you went through menopause? No? No. I don't think that's a correct statement to make, to have been made.
Thanks. Good evening.
Hello.
Just last week, someone said to me that vertigo is a condition of menopause. Is there any truth in that?
Yeah. Everyone deals with will have different symptoms. Yes, there are common symptoms. Now, it's not something, vertigo, that's where the room is spinning or where they are dizzy.
But what causes it to happen? Do you know?
No, I can't answer that. I can't answer that. But I will never discount, but there are other reasons for vertigo that need to be investigated before you say it's something for menopause. Because that would be something that could be neurological. So one, you won't see a gynecologist for vertigo first. You will see a neurologist first. And if they rule out all neurological things, and it's just coincident, it's not a common thing for menopause, and a common symptom, I have never heard of it. But I will never discount somebody who says it, because everybody different. But she wouldn't be seeing us first. She'll be seeing a neurologist first.
But is there treatment for it?
That's outside of my area. But I know that there are persons who, it all depends on the cause of it. Because if it's coming from the inner ear, the ENT doctor might become involved. And if it's coming from here, then the neurosurgeon. I don't know. They have to investigate totally for you to say, oh, I have vertigo, and it could be caused by many things, right?
Hi.
Hello.
My question is like pain during period and before period, is that a cause for concern?
Where do you like pain is?
Like from your hips going straight down?
From the front part or the back part?
The front.
I don't like to tell people, no, it's not a cause. Because, is it affecting your quality of life?
It affects my sleep. I literally can't sleep because this like pain. I used to get severe
You ever had it investigated?
cramps in my stomach, and I no longer get cramps. Now it's the leg pain that is distressing me.
You ever had it investigated? You ever told anybody else?
Well, I'm in
doctor?
gynae clinic, and they not bothered about anything. So, yeah.
Did you have a cut? Did you had any surgery?
No.
And you're in the gynae clinic for that?
I'm in the gynae clinic because I previously
you don't
had...
you don't have to tell...
That's okay.
Okay.
If Merlin talk my business, I will deal with that. I had really, really bad periods, heavy and prolonged, and they had me on medication, but I avoided anything hormonal, so I was on mefenamic acid combined with the tranexamic acid.
It helped?
And it worked for a little bit, and then like my body just wasn't responding to it anymore. And I guess things just started working out itself, where I don't have that prolonged period anymore. It's shorter now on its own, but the symptoms that changing as well. So I don't get the back pain, I don't get the stomach cramps, but the leg pain, the fatigue, the dizziness, yeah,
The period's light now?
the vomiting. You see, you must let them know your business.
It could be something else, you know.
So
It could be something else.
I have asked the doctors about endometriosis. About 2 years ago, I discovered a fibroid. It was like 2 centimeters, so they say it's nothing to worry about. I did an ultrasound a couple weeks ago. It's now 3 centimeters. They just keep saying it's nothing to worry about.
You mind me asking how old you are? Wait, I asked this because if it's that small and it's not affecting because your period's good now, right? You say it's settled.
Yeah, I've always had periods every month, even with the polycystic
Right,
ovaries.
so no real issues with the periods or anything, right? And it's that small. It would be nice, it would be wise to get a person, and I'm talking about you, with similar issues, to as close as possible to the menopause to avoid any intervention.
Pardon? Can you repeat?
Sure, to get somebody with similar situations as close as possible to the menopause being, is okay, because right now, from what I understand, the pressing complaint is
Yeah.
right?
Mm-hmm.
And the initial complaints, which was the periods and the thing, not
Oh,
there
and the
anymore.
frequent urination. That's another thing that keeps me up. But I feel I just consume too much caffeine.
All right. Have a chat when, in your next appointment, write out the questions clearly that you would want to ask them. Ask them if you can see, I don't know, a neurologist or something for that, because they think in gynae in clinic, because there are about 70 people that you have to see in 4 hours. And everybody wants 45 minutes to talk, which you can't do. So write it out. Write it out. It's my suggestion. Write it out so that your concerns will be addressed. So don't leave there until your concerns, because they're going to ask you how your periods are, and you're going to say, well, that's good. I have these concerns. And you focus on those concerns and let them address that there. That's my suggestion. It's not which clinic yet?
San Fernando, Unit C.
That's not my clinic. But yeah. But write out your concerns. That's serious. Because you will write it out. And put it in your pocket, and that's your ammunition.
Okay, thank you.
You're welcome. Yeah, you can still get pregnant. How do you monitor if you get pregnant? No, because with anybody who have irregular periods, if you do become pregnant, they will base it on ultrasound. They won't use your periods. You got to base it on a dating ultrasound scan. It will be hard because.
So, so what, like, how your period used to come, like you hardly, it used to be irregular, and it used to come like every 28 days on the dot, and all of a sudden now it's stopped. Do you still monitor it, like check it like the same 28 days, just, although you're not seeing it, do you still check it like the 28 days, although you're not seeing it?
It will be hard. You can't, no. The only way you could date a pregnancy in that time or with irregular periods is with an ultrasound. Regardless of how regular it used to be, it's how it was now, how it is now.
So you won't know when an egg is released then, so.
If you're not having regular periods, you can't tell if you're ovulating. There's a blood test that could be used to tell if you are ovulating. And for persons who have irregular periods, they have to do this blood test every week until they see ovulation or until 4 to 5 weeks pass. Because we don't know. It's supposed to be the day 21 progesterone. Because at that point, it's supposed to be the highest, and that will signify ovulation occurred. But we don't know what day 21 is in the absence of a period, so you do it every week for a month, for a cycle, to see if any change.
Okay, understand.
Otherwise, just wait till pregnancy and do our ultrasound. And then do our ultrasound. All right? All right. Last question, yeah?
I know a lot of people who have heavy bleeding and long periods, and it was recommended to take vitamin K. Is that good?
I know vitamin K is used as a antidote for persons who taking warfarin. Are they taking warfarin? Do they
No.
have blood clots or anything?
No.
Uh-huh.
They were told that
Who tell them? I just curious.
a doctor that will stop.
The bleeding?
Yeah.
I am not aware of any guidance about that.
Okay.
That's my statement there. I don't know anything about that. You're on warfarin and you have to do surgery now, so you don't bleed out, you give vitamin K. That is what I know. And that's only because something is not working because you're taking warfarin. If this person is in a hematology clinic because some of their clotting factor is not working and you have to replace it with vitamin K, well, I could understand. But a normal person, I can't understand it. I just can't. For no. All right. I take one more question, and then, if any more, and then, yeah?
Just one little comment. I know vertigo too, so I can't.
No, vertigo is not something to be taken lightly. So that need full investigation.
Thank you.
Yeah, and to come back to the menopause, you can't, yeah.
Hi, Dr. Charles. My question.
Ryan.
I had a colleague who had in one of the devices
Which one? The arm or in the womb?
in the womb.
Hormone? No hormone.
I'm not sure.
For pregnancy or for
For
bleeding?
pregnancy. And she was feeling uncomfortable, and it was positioned in a way she said that she could have taken it out for herself.
Yeah.
She took it out and it was rusting. Can you comment on that?
Yeah, I can comment on that, no problem. So that more than likely is the copper coil, right? It looks like copper. It looks like copper. So when it is there, and to address the first thing, expulsion is a risk. Anything that goes in could be expelled. So that's possible. And in terms of rust, the copper that they use in those devices, it's supposed to stay for 10 years. So more than likely, it probably was old. More than likely, it was probably old blood, because remember, blood will look anywhere from red, brown, and that is on top of the coil too that came out, I imagine. I'm not discounting. That could be the 1 in 100,000 that go into rust. But it's very unlikely because they're very, 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 very stable. And that's one of the oldest forms of, outside of the condom, contraception. But I'm not discounting your friend's experience. Yeah, unlikely. All right. Well, thanks everybody. This was. I hope it was nice. Yeah. All right. Okay. Thank you.
Well, Dr. Ryan, thank you for taking time off from your busy